Okay, hello everyone. I am Therese Gardier. I am CME Director for the Department of Urology at Yale. It is my pleasure tonight to have both Dr. Donya Rosen and Israel Franco with us for our third module in our spring CME event. We will be discussing pediatric bowel and bladder dysfunction and constipation tonight. Dr. Franco will be speaking first for us. He is a board-certified pediatric urologist with over 30 years of experience. He currently leads Yale University's Children's Bladder Incontinence Center, which is actively engaged in leading edge research in the field of urinary incontinence and dysfunctional voiding. He received his medical degree from Albert Einstein College and his fellowship from Children's Memorial Hospital, now Lurie Children's Hospital in Chicago. Dr. Franco is regularly invited to speak nationally and internationally at academic meetings in the field of pediatric incontinence. Dr. Franco is a board member and treasurer of the International Children's Continence Society and sits on the Adolescent and Children's Committee of the International Continence Societies, the ICES. Both societies play a vital role in the education of physicians and nurses in the care of children's urinary and bowel continence issues. Dr. Franco has published over 100 articles in peer-reviewed journals, contributed 19 chapters for textbooks, and has been a Castle Connolly top doctor since 2014. Dr. Donya Rosen is currently a pediatric gastroenterologist at Yale-New Haven Children's Hospital. She graduated from Cornell University, summa cum laude, and received her medical degree also from Albert Einstein College of Medicine of Yeshiva University. She completed her residency as well as her GI fellowship at the Mount Sinai Medical Center in New York. She sees patients at the Yale Pediatric Specialty Centers in Greenwich and Norwalk. Thank you both for joining us tonight. It's my pleasure to also work with both of you. So I know this is going to be a really interesting talk. Dr. Franco, we're going to hand it over to you first. Oh, one housekeeping item, I'm sorry. For our Q&A, we're going to ask that you Oh, I'm muted. Sorry about that. So for Q&A, we're going to be doing it in the chat. I will group the questions together and we'll ask at the end, but you can also raise your hand and ask to be unmuted if you'd like to speak as well at the end. So thank you again. Dr. Franco, you're up first. Thank you.
Thanks, Therese. Thank you for the introduction, and thank you, Danya, for joining us for this talk. Hopefully, we'll take different approaches. I'm going to take the urologist perspective on bowel and bladder dysfunction and talk about really some issues with regard to neuropsychiatric issues and the role that the brain will play in some of these patients. If I can get my thing to advance, there we go. So these are some of the objectives, and we're going to see how bowel and bladder and autonomic dysfunction, as well as ADHD and neuropsych issues, are interrelated. So let's start with some simple things such as the epidemiology. And for most girls, they're toilet trained between 2 and 2.5 years of age, while boys are trained typically between 2.5 and 3 years of age. The age in which they attain bladder control is variable, and it also varies from country to country. And what the definition of toilet training is also quite different, in that in China, 1-year-old child may be considered toilet trained. Same thing in countries like Africa or Vietnam. We may see a different expectation of what toilet training is, even though the child may not be cognitively be able to tell that they really need to urinate. And the reference point for lower urinary tract symptoms for dysfunctions in children is 5 years of age. For functional bowel problems, it's considered to be an issue after 4 years of age. And this goes along with the natural pattern for the development of bowel and bladder control, where the bowel control occurs a little bit earlier than the bladder control. And that's usually a sign that I tell parents, if their child is going and hiding to defecate, they're probably ready to be toilet trained. About 25% of all children 7 years old will have some mild to moderate lower urinary tract symptoms, and more significant dysfunction such as daytime wetting occurs in about 6% of girls and 4% of boys. So here, these symptoms: recurrent UTIs, febrile UTIs, urinary incontinence, urgency, frequency, nocturia, nocturnal enuresis, dysuria, hematuria. What do all of them have in common? And that is they all fall under the umbrella of BBD, or bowel and bladder dysfunction. So some of these are going to be very tightly related to bowel and bladder dysfunctions. And similarly, the associated comorbidities with UTIs, reflux, constipation, obesity, and neuropsychiatric disorders are all part and in parcel of bowel and bladder dysfunction. So we separate it into bowel, that Dr. Rosen is going to talk about, and I'm going to talk about some of the lower urinary tract symptoms. So here's a typical problem that we will see. We call this the spinning top urethra. This is common in the patient who is holding urine or trying to hold their urine in, or they come in complaining of dysuria. And many of these children will have constipation, and the external sphincter in this area will tend to be tight, and that causes the compression of the urethra and the dilation of the bulbar of the urethra up to the bladder neck. Similarly, in a male, we see here bladder neck dysfunction that stands out and it's quite apparent. And again, this is very commonly associated with children who are significantly constipated. And this is the final stage of severe bowel and bladder dysfunction that has gone out of control for years. And here's a neurogenic patient with severe lower urinary tract dysfunction, a bladder that looks like a neurogenic bladder, and reflux. And this is, I've seen children go on and develop renal failure who had severe bladders like this. So the algorithm for treatment and evaluation is generally a good history with questionnaires, physical exam, which we have adhered to this even during the COVID. It was impossible for us to see patients with bowel and bladder dysfunction without doing a physical exam, because the abdominal exam would tell us right away whether they were full of stool or not, and then a host of other tests that we do on a regular basis to further define the abnormalities. This is the one of the important tools that we use is the Bristol stool chart, and this will generally give us an idea of where we stand. And the one to the left was a creative use of chocolate that someone came up with at one point. But this Bristol chart is critical for us in helping define where they stand with their bowels. This is a KUB, and we don't do them on a regular basis because we feel that a good physical can pick them up. But if I do have to get a KUB, this picture here is what I usually going to get, which is a lateral film of the spine to make sure that all 5 segments are present. And at the same time, I'm going to see that this patient, who the mother kept on coming back for 3-4 appointments and telling me that her daughter was not constipated. No, she's not constipated. No, she's not. And you're going to find that this is always going to be an issue with many of these patients. Here's another, a CT scan. You could see this thick-walled bladder, which is being likely has gotten to that thick wall because of this tremendous amount of stool in the rectum in this patient. And the other tool that we use that is very useful is the bladder ultrasound. When we measure post-void residual, we're measuring the rectal diameter, and we could see that the width of the rectal diameter will help us determine whether these children have bowel bladder dysfunction. Anything over 3 centimeters is considered to be abnormal. And so this is a general tool. Besides seeing whether they have urinary retention, we're also checking to see whether there is a significant amount of stool in that rectum. As we know, in the role that constipation plays in Lona and Baki's series out of Iowa, which is the landmark article, there were significant findings in her study where they looked at 234 children with chronic constipation. 29% of them had daytime incontinence and 34% had nighttime incontinence, and they had 11% had recurrent urinary tract infections. After they treated their constipation, 89% were dry and 63% were dry at night, and the recurrent UTIs had been completely eliminated, showing this remarkable, and this was in a GI clinic. They were not looking to make any differences in how these patients were managed. So the patients with elevated post-void residuals and had constipation, less than 2/3 had constipation by themselves. And common for, it's very common for stool retention to coexist with voiding dysfunction, which leads to incomplete pelvic floor relaxation. So this is the prevailing theory or this is what's been passed around, that the stool is pushing up against the bladder and it deforms the shape of the bladder and it changes the bladder neck and it causes bladder neck dysfunction and external sphincter dyssynergia. And these possible mechanisms have been passed along: stimulation of sacral reflexes from a full rectum, possible neuromuscular disorders, bladder compression, and behavioral dysfunction causing withholding of both stool and urine. The last one is true, and in many cases, we will see oppositional defiant behavior associated with encopresis, obesity, and children who have recurrent UTIs. So there is a component, and that is true. But the real issue is that there's very good study done by Steve Koff and Benigna, where they placed balloon catheters in the rectum and inflated the balloon catheters when they did urodynamics. And they showed that they could either elicit bladder overactivity or they could elicit elimination of bladder contractions, depending on balloon rectal inflation. So you can see both problems, retention or overactivity with a dilated rectum. It's not exclusive of one or the other. It is possible when the rectum gets overly dilated that you're more likely to see urinary retention, and we see this very commonly. Here's an example of external sphincter dyssynergia associated with too much stool in the abdomen. The area here is the external sphincter, and you can see it's not a stricture. That does open up later on when the patient voids. So the real mechanism comes down to where the nerves leave, and they leave the colon and they go to the dorsal root ganglia and then to the dorsal horn of the spine. If we look at then the other organs in the abdomen, the bladder and the rest of the bowel, they also go to the dorsal root ganglia and end up in the dorsal horn and travel up the cord. The mixing of these signals is occurring at the dorsal root ganglia and in the dorsal horn. And when these signals mix in this area, there's almost a lack of fidelity in that the signals become combined. It's almost like the old I Love Lucy show when Mrs. Trumbull was hearing Lucy on a party line, and she over here. So what's happening here, this is a party line where bowel, bladder, uterus, all other organs are sending their signals. And these signals get mixed and eventually lead to either overactivity or the urge or the need to urinate, because eventually they travel up the spinal thalamic tracts and the dorsal column, medial lemniscus, up to the brain, up into the pontine micturition center, and eventually into other areas of the brain. The other important factor here is that it's now been recognized that the sacral autonomic outflow is sympathetic. That means that the distal colon is being controlled by the sympathetic nervous system, not by the parasympathetic nervous system as it was thought in the past. And so there's this great overlap with the effects of norepinephrine on that GI tract as well. And you could see the sympathetic chain then now involving the rectum besides the bladder. Before, the rectum would have been coming down and involving coming off the parasympathetic outflow. The signals that are then going up into the brain are registering in what are called intraceptive areas. And this is the equivalent of the homunculus for our hands and feet. The insula becomes this receiving area for these interoceptive signals. And then, and this is the area here in a normal person. Finally, they go up past the insula and will then distribute to the anterior cingulate gyrus and the prefrontal cortex, which is going to be here. Okay, and there's different areas, the dorsolateral and the ventral medial prefrontal cortex, and they play a significant role in shifting back and forth in depression. And you'll see that many of these patients with bowel and bladder dysfunction are at risk for depression and anxiety, which are controlled in these areas as well as ADD in the anterior cingulate gyrus. If we look at this image, we see a normal person with normal activation of the anterior cingulate gyrus and deactivation of the ventral medial prefrontal cortex. The patient who has severe urgency has a strong sense of urgency because the anterior cingulate gyrus is strongly being activated in a way to suppress the urge to urinate, and the ventral medial prefrontal cortex is being strongly deactivated to help them control urination. Remember that the parasympathetic area is the ventral medial, and they're sending signals to the external sphincter to stay tight, while the anterior cingulate gyrus is sending that activation to contract, to relax the bladder and contract the external sphincter. We look at a similar image in GI, and we see a very similar finding in patients who have IBS. On this group, these are the controls, these are the IBS patients, and you can see that when a balloon catheter is placed in the rectum in someone who is a normal patient, there's barely any activation at 5 mLs. And then at 25 millimeters of mercury, you start to see activation of the insula and the prefrontal area here. And then you see more activation as time goes on. When you look at the IBS patients, you already see activation in the insula and in the prefrontal area. And then it just keeps on increasing and getting stronger. And when you compare the difference in responses, it's much greater. There's even activation of the amygdala, and the amygdala is involved in fight or flight responses. And many of these people will have these strong amygdala responses because they're actually panicking when they get that urge or when they start to feel this. So it's not unusual to see these patients almost have a panic type response with physiologic responses of increased norepinephrine secretion and tachycardia and other issues that normally go along with that. Similarly, we see that the areas that are involved with control of urination are the same areas that are involved in the control of blood pressure. And you can see from this study on heart rate and blood pressure control that these areas that give us overactivity are the same areas involved in patients who have autonomic dysfunctioning POTS. And that's why it's very common for us to see patients who have Ehlers-Danlos and POTS and stuff like that to end up having voiding dysfunction symptoms and similarly having bowel and bladder dysfunction symptoms. Here's another key element. This is the ADHD patient. This is the anterior cingulate gyrus that's activated in a normal patient. When you see an ADHD patient, they have no activation. And this is why these children will routinely urinate themselves or defecate themselves because they have no ability to suppress the urge to urinate or the ability to suppress the urge to defecate. These children are, unless you treat these children with medication to treat their underlying ADHD, you're never going to fix their underlying wetting and bowel problems. And similarly, we see similar activations in patients who have depression. We also see the same thing with anxiety. That's why there's such a tremendous overlap with BBD in patients who have anxiety, depression, phobias, OCD, ODD, ADD, Asperger's, and autism spectrum disorder. They all are part of the syndrome mix that we normally see. Here's my a sort of parting example. Here's a patient that I treated with severe bladder neck dysfunction, external sphincter dyssynergia. This boy was a C student, came in with severe epididymitis. Someone wanted to do an augment and metrophenol on him because he had such bad recurrent epididymitis. I Botoxed him. His epididymitis got better. I asked the mother if he had any learning problems. He's a C student. He recurred again. We Botoxed him again. This time I asked them to get him tested for ADD. They didn't. He recurred again. I Botoxed him again. Finally, he got tested. He was ADHD without hyperactivity. He went on medication. He never had another episode of epididymitis, never had another voiding issue, and was completely cured. It just goes to show you the power of the frontal lobes in these children and the role that it plays in BBD. So with that, I turn it over to Dr. Rosen, and you'll give us your spiel.
Okay, so thank you, Dr. Franco. And so we will, definitely talk and answer some questions afterwards. So what I wanted to do is sort of take the approach of walking you through briefly how we address constipation from the pediatric GI side of things. So I will tie it into our bowel bladder patients, but also just kind of give you a general overview of how we approach patients with constipation. So I don't know if other people have had this experience, but these were actually from my own Facebook that once I started searching, because parents will come in and say that they have concerns about Miralax or they've read it. So there are actually Facebook groups like this out there saying that Miralax causes psychiatric changes and this is scary. And, so a lot of times we have to dispel some of these myths. So what I wanted to do is to review some of the common causes of constipation in children, and then to talk a little bit more about treatment options that exist, and then in terms of medication, and also sort of how we work up refractory constipation. And I also am a firm believer of diet, so that is something that we also address as well. And then I'll introduce how we run our bowel bladder program at Yale. So 1 in 10 children will get medical attention for constipation at some point. And like Dr. Franco had mentioned, it accounts for about 3% of pediatric outpatient visits, but actually about 25% of all visits to gastroenterologists. So this is pretty much what I'm doing all day long. And so the prevalence is anywhere between 12 to 20% in the United States. So most children will have some issues of constipation somewhere in their lives. And there has been an increase in constipation sort of trending. So the definition of constipation is really any sort of alteration in either stool frequency, size, consistency, or passage of stool that results in colonic distress and discomfort. So again, kind of going back to what Dr. Franco had mentioned, sometimes parents don't think their children are constipated because they say that they're going every day, or they're not necessarily skipping days, not having abdominal pain. But again, if they are having either any painful defecation, if they're passing hard stools, or even if they report some sense of incomplete evacuation, then, which is common in our teenage patients, then they do meet the criteria for constipation. And when we're talking about refractory constipation, it really means the constipation that is unresponsive to our typical dietary manipulations and the use of laxatives that's then impacting quality of life. So these are the children that we're typically seeing. So the issue with refractory constipation is that it's not usually something that is a brief episode. It tends to kind of occur throughout the year. So this was a study that looked longitudinally and followed children for 5 years, and even at the age of 16, up to 30% still had constipation issues. So during normal colon physiology, the colon needs to help propel the muscular contractions, which is that gastrocolic reflex will help mix and then propel contents into the rectum. And again, reabsorption of water and electrolytes usually occurs mostly in the cecum and then the transverse colon. And then the rectum helps sort of propel those contents, and then leads to dilation, which then leads to relaxation of the rectum in the internal anal sphincter. And so during normal defecation, you can see that there's this normal perception of stool, the rectum gets distended, and then you have contraction of the diaphragm, the abdomen, and relaxation of the external anal sphincter, as well as relaxation of the puborectalis muscle, which is this sling. And when we have dyssynergic defecation, like that occurs in our bowel and bladder patients, you can have sort of 2 different situations on opposite sides of the spectrum. So you can either have incontinence, where you have low resting pressure and weakness of the puborectalis muscle, and then that leads to diarrhea and diminished rectal capacity. Or you can have what we see with dyssynergic defecation, where there's prolonged transit time, and then you have this discoordination of abdominal, rectoanal, and pelvic floor muscles. Hold on 1 second. I have a visitor that I tried to lock in the basement. Yeah, I have to do the lock. Okay. Okay, sorry. My bribery didn't work. He's asking about dessert. Okay, so let me see where I was. So anyway, so this is what we commonly see with our patients that have this bowel bladder dysfunction, that they will have this dysynergic defecation. So even, again, they're not necessarily reporting any issues with constipation, but it's more this sense of incomplete emptying, and then they're not having full relaxation of the muscles, which is then leading to more and more accumulation. So this is just, I don't need to go through, but the Rome 3 criteria for constipation, for functional constipation, which is more common. So, frequently when patients are coming to us, they want to know if there's any sort of underlying medical issues that need to be ruled out. So we usually tell them that greater than 95% of the time, constipation will be functional, meaning that there's really no underlying medical issues that we need to be concerned about. That being said, these are some of the warning signs that would alert you to, maybe pursuing a little bit more of a workup. So for example, if symptoms really started less than 1 month of life, if there's delayed passage of meconium, if there's any family history of Hirschsprung's, severe abdominal distension, looking at the anal positioning and if that's abnormal, or if there's a sacral dimple or tuft. If there's a family history of autoimmune disorders, that may propel us to do some blood work just to make sure there's no other autoimmune conditions such as thyroid or celiac. If there's a rectal fistula, and then when we check the anal tone, if it does not seem, if it's either, almost like an anal stenosis, or if it feels very weak. Otherwise, we will typically start with the approach to more functional constipation, more in terms of diet and sort of, general education, and then pursue further workup if it's not improving. So one of the questions that I like to ask is, when did the constipation first start? Because this is going to help you figure out if this is more functional versus organic. And a lot of times we're told at birth, and especially, if we have 3 or 4-year-olds, it may seem for the parents like this was an issue that's been going on their entire lives, but it is really important to know if there was normal passage of meconium. Because if a baby has been growing well, growing along their growth curve and past meconium, then the likelihood of a missed Hirschsprung's is very unlikely. You may have a short segment Hirschsprung's, but that is going to be much more rare. So the typical times to see constipation are with the introduction of solid foods at around 6 months, introducing whole milk at 12 months, and then really the initiation of potty training. And I find that a lot of times, parents will claim that children were fully potty trained, but typically there were some issues around that age. So in terms of treatment, I usually tell parents that it requires sort of a triad approach of medication, diet, and behavioral changes. And oftentimes it really does require a combination of all 3, but every once in a while we'll see, maybe a child who it really is standing out to be more an issue of one of these things. So in terms of treatment, if we have palpable stool that you can feel on exam, often they're going to respond best to doing a clean out. So especially if they have any hard stool where you can either feel in the left lower quadrant, or they kind of have fullness, in the right quadrant, I tell parents that the intestine is sort of shaped like a question mark. So anytime that you feel it, again, much higher up, they're going to respond better to maintenance if you have them and do a clean out first. And so usually we'll do a clean out followed by a maintenance phase. And depending on the stool frequency, I find that helps figure out, would they be okay on just a stool softener, so something, an osmotic laxative such as Miralax, or are they going to need more of a stimulant laxative? And this is getting into our bowel and bladder patients a little bit more, that typically when children are either not having bowel movements every day, or if they're having that sensation of incomplete emptying, and again, because there can be this dysynergic defecation and this crosstalk, both physically and then at the level of the spinal cord, often children who have both bowel and bladder issues are going to do better on a stimulant laxative such as Senna. And that can be the Senna-Cop pills, it can be the chocolate X-Lax squares, but I find, and I know Dr. Franco agrees, that doing Miralax alone in these children is not going to get you very far. And sometimes it can actually even make it worse, because then you sometimes have leakage of soft stool and they're already not sensing it, and then it can even lead to more accidents. In terms of fiber, I try to stress the difference between soluble fiber and insoluble fiber. so that they're getting, fiber from fruits and vegetables as well as whole grains. And we have a dietitian in our office. And, sometimes I do, when I have time, try to take a brief dietary recall and just try to figure out some ways where they can maybe introduce a little bit more fiber into their diets, whether it's snack foods, whether it's, maybe they still are going to do their regular pasta, or they can do, enriched pastas, that sort of thing, but then maybe change over the cereals. And then actually adding things like flax seeds or chia seeds to smoothies, to oatmeal, to yogurt, actually go over pretty well too. And then again, in terms of behavioral, it kind of involves, I'd say, two sort of things. One is doing set toilet times, because you're going to have a stronger gastrocolic reflex for bowel movements after meals. So we have had psychologists that work in our office as well, and they say, it's sort of a pick your battle sort of situation. So we want children to be sitting, but at appropriate times, so that we can really time their toilet sit well. When we have a child who has bowel and bladder dysfunction, and they're having this urinary dysfunction as well, then it can be a little bit more challenging to figure out a good toilet routine, because then from the bladder part of it, they're going to have to naturally do more toilet sitting times throughout the day. So that's when sometimes having a watch or a chart or an alarm may be more helpful. And then I also, in terms of limiting distractions, it kind of depends on the age and the situation. If you have a younger kid who's not going to sit for more than a few seconds, it may be helpful to have some sort of iPad or device that they can use to help them sit. But at the same time, for older children, they're sometimes sitting on the toilet, and actually too much straining will place excessive strain on the muscles and can sometimes confuse the relaxation of the internal and external sphincter. And so sometimes that can kind of contribute to this dyssynergic defecation. So I actually will encourage them to try to not bring any devices into the bathroom and really limit the amount of time. And then it tends to lead to improvement. Just to kind of briefly talk about a couple of other treatments that we use. So there's actually no great evidence that probiotics help with constipation. This is from our NASPGHAN 2014 guidelines, that there's really no evidence from randomized controlled trials that probiotics of any type have an effect on constipation. I think it can be a little bit misleading to parents, because you do have some probiotics like Culturelle Kids that are now marketed with fiber. So sometimes that can be helpful, but I would say it's more from the fiber component, not necessarily the probiotic itself that's really causing any magic. But sometimes using more of a fiber supplement could be helpful, such as a Benefiber. So getting into the treatment, and this is another one that I found. So basically, like I mentioned, Miralax is really just an osmotic laxative that helps to increase water content in the bowels. It's non-toxic, it's biologically inert. There's really no studies that show that it affects any electrolyte imbalances, even when we're doing bowel cleanouts and anything like that. And again, because it is just an osmotic laxative, it's going to soften the stools, but not necessarily cause any stimulation that's going to cause any sort of cramping. So it has its place, but for the right patient. And there was a study that was published with some of my Yale colleagues, so Dinesh Pashankar and Uma Fatak, who looked at the sort of palatability and effectiveness of Miralax compared to other osmotic laxatives, such as lactulose and milk of magnesia. And they basically found that the Miralax was both more effective and then also more palatable, so better tolerated and more likely for patients to stick with it long term. So, so we use these others such as lactulose and milk of magnesia as alternatives sometimes, but I would say that Miralax is still our go-to. So then when we're talking about other stimulant options, like I said, especially when there is evidence of either bowel and bladder dysfunction or dyssynergic defecation, using a stimulant laxative is going to help them retrain the gastrocolic reflex a little bit better. So that's when we tend to use some either senna-based medication. So like I mentioned, either the Senecot pills or the chocolate squares. Bisacodyl is Dulcolax, and it exists as the pills. It actually can exist in a liquid form that you can get, although some pharmacies will compound it. It's not very widely available. And then also there's Dulcolax suppositories. And so this is a little bit more of a prokinetic and actually can be used in children with severe dysmotility as a long-term medication. And then two relatively newcomers to the field that we will use in some of our older children with irritable bowel constipation type are either Amitiza, which is lubiprostone, and Linzess, which is linaclotide. And these both work on the intestinal channels over time to help increase stool frequency and increase frequency of bowel movements, while also helping with the hard consistency of stools. And these generally are long-term medications. So again, I usually reserve this for teenage patients who already have sort of maximized the fiber intake in their diet. They're doing their toilet sits, and even on high doses of senna, they are not really responding. Then sometimes these prescription medications can be used. So, like I had mentioned briefly, I just wanted to throw this in there just to be thorough. But if you do have a child that we're concerned about Hirschsprung's, that ultimately doing a rectal biopsy will be sort of our gold standard. So not something that we're doing very often in older children. We usually start with a barium enema, but this is something that we have seen in older kids as well, so just to mention. But what you may have seen us doing in some of our patients now, especially with this bowel bladder dysfunction, is anorectal manometry. And so this is a test that we now offer. We have the equipment for it in the Greenwich office as well as up in New Haven. And it really helps just give us a good idea of whether there's dyssynergic defecation that's occurring. So basically, Therese will get the patients in position and kind of get them hooked up to this monitor. And there's a small probe with a little balloon that inflates. And the test takes about 20 minutes or so. And for some of it, the child is really not having to engage much. They're really just kind of lying on the bed. They can be watching their iPad, watching, playing on their phone. And for some of it, it's really just taking baseline measurements, like the resting pressure, squeeze pressures, and it helps us see whether there's actually any sort of abnormality with the pressure sensation or the musculature. And then we have them, it actually blows up a little bit of balloon. It can be water that gets inflated. And then we can see if the sensation is appropriate or if it's delayed. Because if there is delayed sensation or they're unable to really feel the balloon at all, then that gives us a clue that there might be some dyssynergic defecation, in which case they may respond well to biofeedback. The other thing you can do on anorectal manometry is test for the RARE, which is the rectoanal inhibitory reflex. And if you're able to see that on the tracing, then you can basically rule out Hirschsprung's, and this can be done even in young infants. Let's see, what else did I want to mention? Also, again, if, like Dr. Franco mentioned, occasionally we'll be concerned, especially if there is a dimple, that there may be a tethered cord or some sort of lumbosacral abnormality. So I've had maybe 2 patients a year where there's some abnormal findings on a KUB that then prompt me to get an MRI. So that is something that we'll consider as well. And then the other thing just to mention is that now at Yale, since we have a little bit more of a recruitment of some motility folks from Boston Children's, we now offer colonic motility as well, which I don't think is being done anywhere else in New York or Connecticut. And so basically, if someone has abnormal anorectal manometry, then it, in certain situations, may be helpful to actually do full colonic motility to see if they really do have some sort of motility issue. And if they do, and you don't see the correct propagation of the contractions, and this is sort of worst case scenario, I'll just skip this, that you can actually do what's called an ACE, or an antegrade continent enema. And it basically involves, it's almost like a G-tube that's getting put into the cecum. And through this, patients can do like a saline flush, and it helps propagate some of those contractions. So especially if there's really abnormal motility, it helps stimulate through these flushes. And actually the interesting thing is that this is not necessarily a long-term problem, that oftentimes eventually the colon will sort of regain function a little bit more, and in some situations the ACE can actually be reversed. So I wanted to just briefly mention, I think we can then go to questions, our Yale Bowel and Bladder program. And so what we had started to realize was that through different, whether it was GIs or different urologists in the area, that people sometimes had different approaches, and which is fine. Not everyone, practices the same way, but what was sometimes happening is that patients were getting frustrated because they were being told one thing by one doctor and being told something else by the other. And so they almost felt like ping pong balls going between, the GI and the urologist. And this one said to increase the Miralax, this one said to decrease it. This one said to take the, Senna at night, and this one said to only take it in the morning. And this one said to do, clean outs on the weekends, and this one said no. So basically what we wanted to do is really provide a comprehensive approach for patients so that they can see both our GI and urologist, but walk out with one firm plan. So what we now do is we have designated clinic sessions, which right now we've been doing the first and third Wednesday afternoon of the month, starting at 1 p.m. and going through the whole afternoon, where patients who need to be seen by either, actually for both GI and urology can have booked appointments with both specialties. And then we will talk, convey, sometimes, we're in the room together, sometimes it's separate, but, even in terms of their after visit summary that they walk out of the office with, that they really just have one firm plan of where to go. And we have nutrition support as well. We have social work, and, because there is often this, complicating factor of either, some attention deficit disorders or school issues, we can really work with them to provide a comprehensive approach. We also offer, like I said, the anorectal manometry. We'll do the Uroflow EMG, ultrasounds, and then biofeedback, just to keep the clinic running. Oftentimes the anorectal manometry and the biofeedback wouldn't necessarily be done at that visit, but the ultrasounds, the Uroflow, and if we did need to do, an X-ray or KUB beforehand, oftentimes we're able to accommodate all of those things together. So, I just wanted to end by saying that I think oftentimes there is improvement in diet, but unfortunately probably not going to get you very far once you're already at this point of having this bowel and bladder dysfunction. And so the treatment for both this bowel and bladder dysfunction is often very common. And so it's important to have a good relationship between the GI and urology so that our patients do well. That's it.
Thank you very much. That was excellent. Both talks were really very good. Thank you, Dr. Franco and Rosen. I do have a couple of questions that people have texted me. Please feel free to use the chat or raise your hand and we will unmute you. Dr. Rosen, can you give us your thoughts on using magnesium calm, which, the gummies, the mag citrate gummies, as a supplement and its efficacy for constipation? And also curious to hear your thoughts about timing of when to give patients Miralax, morning, afternoon, or night. I guess do that first and then I'll do the next.
Okay, sure, yes. Thank you. So I'll start with the second question first. So typically with Miralax, I find that because it is an osmotic laxative, the timing shouldn't matter. So it usually will still sort of mimic the time that the child will normally have a bowel movement, but just make it easier when they do go. So I find that because the Miralax dissolves better in water or juice, we tend to try to avoid milk for that reason. Miralax often people will do in the morning, in some juice, and we'll be fine. What sometimes gets a little bit more tricky is if we are putting them on Senna, figuring out the timing of that, because we don't want to give them senna in the morning before they go off to school, and then they feel like they have to have a bowel movement at 11, 12 o'clock. So what we'll sometimes have to do is figure out on the kid's schedule, does it work to do, when they get home from school? Sometimes we'll even have a school nurse administer it. Some kids, if they do have a little bit of a more delayed reaction, so they can do it at nighttime and have a bowel movement the next morning before school, but that does require a little bit more coordination. In terms of magnesium supplementation, I think it depends on the age, first of all, because I don't like to do high doses of magnesium just because it does concern me a little bit more for electrolyte abnormalities. But in terms of the calm gummies, I think that's often a fine supplement. I think I would position it somewhere between, it may help a little bit, but it's not necessarily going to be strong enough on its own to really regain that gastrocolic reflex.
Okay, thank you. It seems the latest recommendation is not to use KUBs to diagnose constipation when history is unclear, as they are not sensitive or specific. Can you please comment on this?
I'll take this one too, and then Izzy might have something to add. So oftentimes, I think when we're doing a KUB in the office, I find most of the time, physical exam is sufficient. Sometimes when children are obese, unfortunately, because they have so much subcutaneous fat, it can sometimes be difficult to fully palpate this colon. So that's a situation where I will sometimes get an X-ray. The other is sometimes when we've already done a clean out and we're not sure if a child is fully cleaned out prior to starting the maintenance phase, that would be another situation where we'll sometimes get a KUB. So it's more to assess response to a clean out, I would say. Oftentimes parents will ask at the beginning if the X-ray is necessary, and I tell them I'd rather save it. So if we know a kid's constipated, we don't want to do any tests. That's not going to change our management. So I'd rather save it for, if we need to gauge that response.
Right, and
The other time that we get KUBs is when the parents have oppositional defiant behavior, meaning that they refuse to accept your diagnosis of them being constipated, and you need to prove to them that the child is full of stool. Since it's very common for constipated children to have ODD, the parents are likely to have ODD as well. So, it's not an unusual event.
I just also wanted to add that when we do the KUBs, speaking to the sensitivity of them, they will often correlate with the rectal diameters that we do on sonogram. The measurements are actually fairly close, and we can show both ways. So I do think that where they're not 100% sensitive, there is definitely good use for that. Next question is, what do you say to parents that say, I don't want my child to be dependent on medication for the rest of their life? And I guess also commenting about habit forming use of senna.
So
Izzy, you want to take this one?
You want me to go, or you want to go?
I like your answer for this one, so I'll let you take this one.
So basically, my answer to most people is, I ask them a question: are you constipated, or who else is constipated in the family? Okay, almost invariably, they will tell me that someone in their family has severe constipation and that they've had it all their life. So I make it clear to them that the probability that their child is going to fall into the same category as them is pretty high. And the likelihood that they're always going to have this problem is pretty high, that it will continue on. And they're going to probably need something, whether it's diet or senna or Biscadol or whatever else is needed. And in some cases, we've had, other people remain on other drugs as well.
And I will say this is actually, again, it depends on the clinical scenario, but this is where sometimes the anorectal manometry can actually be positioned. Because if you have a child who has dyssynergic defecation, and that's the reason that they're still dependent on medication, then if they're a candidate for biofeedback, which kind of trains them how to relax the muscles appropriately, that may be a child who does not need long-term medication if they're compliant with the, with the biofeedback program. So we successfully do get patients off of medication.
What is the reliability of the Rome criteria in deciding whether constipation is present in children with BBD?
I mean, I would say, again, because we work closely together with our urologists, that with children with this bowel and bladder dysfunction, and you can correct me if these are not the correct numbers, that about 50% of the time that constipation is present, it will be affecting the bladder issues. So what we will typically do, regardless of whether they meet the criteria for constipation, is put them on a trial of, a stimulant laxative, and then see what happens with the urinary symptoms. And if the urinary symptoms get better, then constipation was playing into the bladder dysfunction. But if you've treated constipation and it makes no difference, then they may be more of a candidate for any of your, other drugs, or it may be isolated sphincter dysfunction.
The other answer to that question is I've always stuck to what I call the Iowa criteria, which is Lonen-Baki's criteria for constipation, which is not as extensive as the Rome criteria. And basically palpation of stool. And I think this is a test that anyone who does a good physical exam and watches these children, when you palpate stool in children who have BBD, almost invariably within 5 to 10 minutes during your visit, they have to go run to the bathroom to urinate, or they go run to have a bowel movement, because what you're doing is you're stimulating their colon. And to me, that ends up being the most definitive test to show an association between constipation and BBD.
Yes, that is true. Another question, what do you do with autistic child who holds their stool to the point they are in agony requiring digital disimpaction? What would be a good maintenance for drug therapy? The child loves her milk.
Yeah, that's a hard one. Typically in that situation, we do try to maximize the dietary therapy as much as possible. So, sometimes giving them a limit on how much milk or dairy products they should be taking, and making sure that the water intake is adequate as well. But oftentimes in that sort of situation, I would still start with a laxative, with an osmotic laxative. So I think, either Miralax or, perhaps, maybe like magnesium gummies in that sort of situation could be helpful. The problem is when you have a lot of, and sometimes this is where Senna gets a bad rap, is that if there is a lot of stool that's sort of locked up in the colon, and then you add a stimulant laxative, it can sometimes worsen the cramping, and it's going to make the problem worse. So I would say that probably a good trial of an osmotic laxative would probably be more helpful prior to jumping to a stimulant laxative.
I think also this is a place for good behavior modification, working with occupational therapists. I have a couple of autistic children I'm working with now, and we've been successful using some rectal therapy, believe it or not, with some pre-medication beforehand to lessen the anxiety and desensitize them a bit. So I think that's about it. We're just over the hour for tonight. Thank you both very much for joining us. These were excellent lectures. We will send out links tomorrow. This will be recorded and can be viewed even if you did not register for tonight at a later date. So thank you all very much. That's a wrap.
Thanks, Therese.
You're welcome.
Thank you all for spending an hour with us.
Thank you.